Hi everyone, my name is Camilo and I'm a current fourth year medical student at IU School of Medicine. In this presentation, we will be covering ankle ultrasounds. Specifically, we'll be covering indications for study, common pitfalls, material and approach, anatomic structures, and common ankle pathologies. Now, we will begin with when should we ultrasound an ankle? As you might have guessed, it can be for any injury to the ankle. Ultrasounds serve as a phenomenal bedside assessment that complements a physical exam, and when applied to Ottawa's ankle rules for imaging, it can even reduce the number of x-rays obtained without underdiagnosing fractures. In cases where we do get an x-ray of the ankle, the ability to interpret the image can be limited by the degree of effusion present. In such moments, an ultrasound can evaluate for fractures or tendinopathies with a high degree of sensitivity. In discussing ultrasounds, it's only fair that we mention common pitfalls, one of which is the concept of anisotropy. Depending on how steady the user's hands are, the probe can slightly move off its target and interrupt the view, which can result in the image being interpreted as a partial tear or tendinopathy, when in fact the tendon is perfectly healthy. We will have an example of this concept later in the presentation. Another pitfall is that ultrasounds are not as effective as X-rays or CT scans in detecting navicular fractures. Whenever you have concerns about this, an X-ray should always be obtained. For the materials, we will be using a linear ultrasound probe set to the musculoskeletal setting as well as gel. We will have our patient start in the supine position with his ankle flat and the area of interest exposed. We will also have a towel placed underneath the affected ankle to reduce strain on the affected area as well as flatten the contours in order to maximize the probe to surface contact area. Lastly, we will be applying the probe directly over the ankle, being mindful of pressure, as well as obtaining long axis and short axis views. In this video, we have our patient lying supine as we place the probe in a longitudinal fashion in order to visualize the anterior tibio-talar joint space. To the left of the screen, we see this smooth hyperechoic structure indicating the tibial head, and off to the right, we can find the hyperechoic structure denoting the talus. The patient is now dorsiflexing his ankle in order to provide greater visualization of this ligament. We now rotate our probe and slide laterally in order to gain a short axis view of the anterior inferior tibiofibular ligaments. We reposition our probe in order to get a more central view of the structures, and to the left we find the smooth hyperechoic cortex of the fibula, and to the right we see the tibia, and immediately connecting the two, we have the parallel lines of the ligament. We now slowly rotate in a clockwise fashion the distal portion of our probe to visualize the anterior talofibular ligament with the fibular head on the left and the talus on the right. And we can see this hyperechoic structure connecting the two, denoting that respective ligament. We will now place the probe in a longitudinal position over the fifth metatarsal. We scan along the left of the metatarsal and include the base, and in doing so, we can visualize the peroneus brevis muscle to the left, along with its tendon and site of insertion in the base of the fifth metatarsal. The smooth contours reassure us that there are no signs of fracture or other pathology, or any form of edema or rupture within the muscle and tendon. The patient now rotates to lie prone in order to grant us direct access and visualization to the Achilles tendon. Placing the probe longitudinally, we immediately see the typical tendon architecture of parallel fibers running, and we can trace it superiorly and inferiorly as well to the site of insertion along the calcaneus, which is denoted by this smooth hyperechoic cortical line. As was previously mentioned, we can see the concept of anisotropy when my probe slightly moves from the tendon tract. However, we correct this by realigning our probe and in a side-to-side sweeping fashion confirmed that there is no pathology of this tendon. We will now begin a review of common ankle pathology, starting with a video of joint effusion, specifically seen in the tibio-talar joint space. In this video, we can see this hyperechoic structure connecting the two bones with individual parallel lines denoting the fibers that indicate the anterior tibio-talar ligament, and this mostly anechoic fluid surpassing the joint space and compressing the more superior structures. In this image, we see the tear of the anterior talofibular ligament. The fibular head is denoted by this hyperechoic cortical structure seen on the left side of the image, with the talus indicated on the right. We can see the ligament superior to these two structures, and with heterogeneous echogenicity denoted by the arrowheads, with marked fluid edema superior to the fibular head, denoting tendinopathy as well as rupture. This can be seen in forced eversion maneuvers commonly seen in sports injuries. With this video, we visualize complete rupture of the Achilles tendon. This can occur with forceful contraction of the calf muscle that becomes too great for the tendon to support, commonly seen in stop-and-go sports such as tennis or basketball. In the image, we see two tendon stumps with marked fluid collection in between the space. To recap, we have reviewed indications for an ankle ultrasound, pitfalls, materials and approach, anatomic structures, and common ankle pathologies. This concludes my presentation. Here are the links to the images used, as well as to additional readings. Thank you.